comment because from all the studies that we know, the long-term result of any bifurcation is primarily dependent upon the excellent result in the main branch. If you don't have good result in the main branch, your preserving the side branch does not cause so much of a benefit. So I feel any bifurcation at the end of the procedure, come what may, we should show that the main branch is perfectly there. Am I right or am I wrong? I think this is the concept which I understand.
That's an excellent point. I agree completely with you, but you cannot lose such a big diagonal. If not, get 1,000. Okay, your point, please?
That's fine. Very valid point. First, we have to concern about the main branch, which is much larger than the diagonal. First, we have to concentrate first what he did. He approached the diagonal first, and he was fortunate not to have thrombus gone to the main branch. And then he might have faced a lot of problem at that time. So first, he totally neglected the importance of thrombosuction, which was very, very important in this case. And rather to give a oral anticoagulant after that. So first, we have to have a thrombosuction done. In this case, what I feel, from both the diagonal and the left main branch, and then first tackle the main branch, and then tackle the diagonal. I think it will be the better approach rather than going. He might be fortunate this time, but may not be next time.
Okay. No, I agree. We all agree on the main branch, but I think that the operator and the two discussants didn't discuss about the fact that the main branch has to be treated properly. It was treated with a big stent, so I agree on that. I think we all agree on that. About medical environment, I think that's most. I think the two of you wanted to aspirate. Marco, can you make a comment on that?
Yes, definitely. Here I would have aspirated in both vessels. But I have a question. So initially the patient was not on glycoprotein 2 beta receptor inhibitors. So you just gave bivalirudin and prasugrel.
We did not give bivalirudin. We did not give 2B3A blocker either. We regularly check the platelet aggregability in these patients. And with aspirin and prasugrel, his platelet aggregability is very low. And I find we almost stopped using 2B3A blockers of late with the availability of this test. With prasugrel, the inhibition is so good that I really did not find the need. Can I take up the other two questions which the audience have asked at this point? Yeah,
sir, you know, one more very small suggestion to make. He's a 34 years
sorry, old. We can't hear you very well.
I'm just small. One more suggestion to make. He's a 34-year-old young patient. We have to rule out systemic problem like hyperhomocystinemia, because even if you treat the patient for the local problem of the stenosis, subsequently, eventually, if you don't treat hyperhomocystinemia if he has, then he might develop a rethrombosis, which is going to be problematic. His anemia also could be related to hyperhomocystinemia with acquired B complex deficiency. So there is a very important thing in the long-term outcome of the patient. So you can't forget that.
Okay. The reason we did not consider thrombectomy, thrombosuction seriously was that I find there is a very tight lesion at the ostium of the diagonal also. I was skeptical whether I will be able to push the catheter beyond that point, one. Two, it is a relatively organized thrombus. You can see here. My experience with export catheter especially is that in the acute stage, you get very good results. You can suck out a huge thrombus. But in a case like this, where it is already opened up, you can see layers of thrombus going into the diagonal. You will just go in and come out without much help from the thrombosuction. So in relatively settled cases like this, 4 or 5 days old, I am very skeptical about using thrombosuction. The homocystinemia, etc., are not of great relevance in this case because you have two very glaring risk factors, smoking and diabetes in this patient. And anyway, one can investigate this patient later.
Sorry, you will get a microphone. I like this heavy discussion. I want to make a point. This is clearly a very unstable situation. The patient has pain at rest, is well described, and visible thrombus everywhere in that lesion, in LAD, in the diagonal. So I would aspirate first too. For sure, to try to clean as much as possible this artery. And
How you decided there was a tight osteal lesion with the thrombus? How you presume that it's a tight lesion without just assessing the lesion? How you decided that it's a stenosis only, it's not thrombus?
No, the stenosis is there in the diagonal ostium, as you can see. Thrombus is also there. There is no doubt about it. You are trying to say, doctor, that it is the thrombus which is giving you an impression that it is obstruction. That's what you are trying to say. No, I think there is a lesion. It is a Medina 111 in this case. The tightest point is in the diagonal. Tightest point is in the LAD after the diagonal, but there is an equally significant lesion in the ostium of the diagonal. The mild lesion is in before bifurcation.
Ma'am, one more point which I wanted to bring was, after 1 month, does the thrombus remain like that? Because we rarely see thrombus remaining in that region after 1 month. So is it something other than thrombus? I think even that has to be looked into.
Yeah. No, I think it's clearly a thrombus. It has resolved partly under the effect of oral anticoagulants.
No, I think fairly relevant comments have been made by the audience. But the question is that the trials that we are talking of, one stent vis-a-vis two stent techniques and restenosis in the side branch and the results in the main branch are, majority of the cases are dealing with osteal lesion of the side branch. It is up to operator to decide if the lesion is long, if the lesion has an unstable plaque like as this case is, and if it is serving the large quantity of myocardium, then I think the decision of two stent is to be made in the beginning. So in this case, I go with you, with him, that it will basically be a two-stent technology, and that decision has to be made right from the beginning. A provisional stenting or a two-stent definitively is right from the beginning. I also, like you, feel that this kind of clots are difficult to aspirate, very difficult. And radiological appearance to differentiate thrombus, dissection, thrombus plus dissection is difficult. And why did thrombus come in this area? Probably there was an unstable plaque which ruptured and produced a thrombus without leading to total occlusion, but unstable angina and acute coronary syndrome. I think to be able to aspirate is not going to be easy. The other thing that could be that whilst the patient was under observation in ICU, treated this patient a few days with, now abcicimab, you can't equate with the platelet reactivity blocked by the antiplatelet agents. No. Abcicimab has additional action. One, it is dethrombotic, it acts against vitreonectin, and it is anti-leukocyte. And it is much more specific in, that's the only antiplatelet agent which is antithrombotic. It could dissolve the thrombus itself. And the results of, everybody knows by experience, that the results of Riopro abcicimab are always superior to a dual antiplatelet given orally.
So,
maybe just one comment, sorry, at the end. What do you think? There may be also a component of plaque protrusion, because the fact that that remains 1 month after, I agree, what the colleague said is unusual. So do you think is that what we see now is residual plaque protrusion?
Personally, I think it's the thrombus. The fact that it was a huge burden at the end of the procedure, two, relatively less after 1 month. I would say that the thrombus has resolved partly under the influence of the oral anticoagulants plus antiplatelets. I will just come to the question of abcicimab in this case. The abcicimab helping patients, the data was all in the pre-clopidogrel and pre-prasugrel days, when they were giving aspirin and they gave abcicimab and they showed very good results. Now in patients who are treated with prasugrel and aspirin for several days, you achieve good. Of course, the data on the third point is lacking, that if you have good platelet aggregability inhibition versus no inhibition, abscesumab, that I cannot tell. But if you see carefully the ACC/AHA guidelines, they removed the abscesumab or any 2B3A blockers usage from being mandatory to maybe desirable in patients who are post-aspirin plus clopidogrel. So the data of those trials, which are done with the BRAVE2 trial, etc., they are all showing that abscesumab did not really make much difference in these patients.
No,
Okay.
but you used warfarin, no? That was empirical then.
Sorry, there is, he wanted to ask.
I think, one of the concern I had in this case was the anemia. Otherwise, I would have preferred to give him antiplatelet drugs and enoxaparin and maybe 2B3 IV infusion for a couple of days and see. That way, you don't even run the risk of distal embolization by thrombus aspiration or something else. So that would have cleared some clot before you did an intervention. You had TIMI3 flow when you did the angiogram. There was no urgency to do an angiogram. But the concern here was whether it is possible to give all these medications because patient may have some type of bleeding going on. That was also a concern.
Okay, I think we are supposed to finish, but I would like to ask a final word as the old lady that I am. The warfarin doesn't help at all in this situation. You just increase your bleeding. Yeah. Think to a very old publication, 91, that we did, coronary stenting without Coumadin. At the time of Coumadin, 10% of the stent occluded because those problem is a platelet one, not another pathway of the coagulation. So I do not recommend in any case using Coumadin after stenting. It doesn't help. You can do whatever. I agree that with prasugrel and aspirin, when you test, they are as low as with Reopro. So, but. It's time to conclude. Your final word, because you did the case.
Okay, I agree with you. There are points when can criticize this case, the way it is managed. But either way, I think whatever you do, you would end up getting criticized in this case. There's no one sure way of treating this patient. We even considered at one point of time, we discussed this case several times. It's the first time I had a case like this, that you have a lesion, you have a thrombus, you have a very big vessel as a side branch, whether we should put a stent graft into the side branch and then put a routine stent into the vessel. But then there was a scare that if by chance you are mistaken and if it comes inside, you will close the entire vessel. So the multiple options can be considered. But at the end of it, I agree with you. The oral anticoagulant idea came to me because I was very concerned whether this thrombus is going to close the vessel. We kept him, in fact, for 2 weeks in the hospital. So we gave him anticoagulation for several days. Then it came to me, if I am giving anticoagulation and he has not bled or anything, why not give him oral anticoagulation and send him home? In fact, the patient wanted to go home, and that's how we ended up giving. This is the first time we did it in a PCI case, oral anticoagulants after maybe 15 years.
Okay. Thank you. You got a very good result, which is the most important. Thank you. Let's go to the next case.